Welcome to another episode of Cracking Addiction. My name is Philippe Naren and I'm a GP and Addiction Medicine Advanced Trainee here in Melbourne. And as always, I'm joined by Dr. Fergal Armstrong, who's a GP, as well as being an addiction specialist and lifestyle medicine specialist. Fergal, good to be on the show with you again.
Great to be here again, thank you.
So today we're going to be talking in a bit more detail about alcohol withdrawal management and the practicalities of alcohol withdrawal. There's usually two ways we can differentiate alcohol withdrawal. There's residential withdrawal and outpatient, home-based or community withdrawal, whichever title you want to talk about it. So Fergal, I thought we'd start off talking about outpatient withdrawal, so home-based withdrawal. What would be some of the main aspects that we need to consider about home-based or outpatient withdrawal?
I think the most important aspect is patient choice. You need to have a clear understanding of what kind of patients can be safely provided with non-residential alcohol withdrawal. And there are a number of factors, things like, mono-substance dependencies, so no other alcohol dependency, no significant mental health disorders, no significant comorbidities in terms of physical health. And also there are some situational or environmental factors. So for instance, you need the presence of another responsible adult during the withdrawal. You need a safe drug-free house during the withdrawal. You need to be able to see the patient every day during the withdrawal, and the patient's got to be contactable at all times. So each of those in turn then entails further consideration. So Philippe, let's go back to the patient factors. So, mono-substance, is that an issue, do you think?
It very well can be. There are people for whom alcohol is the one and only substance that they use. But practically speaking, a lot of patients that I see are polysubstance users. So alcohol is just one of the substances they're using. And in a situation like that, I would be very reluctant to do a home-based withdrawal just due to the risks of harms of some of the medications that we would be giving for the withdrawal management, which we'll get to later on in the episode. But yes, there are also quite a few people who are mono-substance users, whereas alcohol is the one and only substance they use.
Yeah.
And a situation like that, exactly as you mentioned, Fergal, you risk stratify the patient and make sure that they're able to comply with an outpatient program. And I must say, although in Australia, home-based or outpatient withdrawal management probably isn't as popular as in other parts of the Western world, with the right patient selection, it is a very safe, worthwhile and effective intervention. And it is something I think we should be doing more of in this country. Would you agree?
Yeah, definitely. I think with the right choice, with the right approach, it is definitely a safe therapeutic option. But going back to some of the inclusion-exclusion factors, what kind of physical and psychological comorbidities would mean that you would be preferring to put a patient into a residential rather than non-residential withdrawal?
I think if someone had a psychotic disorder, schizophrenia, severe depression or anxiety, mild depression or anxiety would not be an exclusion criteria in my book if the patient was well managed, well medicated and stable. But if someone has severe psychiatric conditions where the stresses and pressures of undergoing withdrawal, and bear in mind, withdrawal is a very unpleasant situation.
Well, at least can
so
be.
If we're putting someone, well, it can be, sorry. But if we're going to put stressors on someone who's vulnerable, we want to make sure that they're robust enough to go through that. So if I have concerns that the psychological or psychiatric condition could be flared by undergoing withdrawal management, then I think a residential withdrawal is probably the safest aspect. Is that your practice as well, Fergal?
Yeah, pretty much so. What's your view on borderline personality disorder? Is that an absolute contraindication to a home-based detox? What do you think?
To me, no, it's not. As with any condition, borderline personality disorder, complex trauma, those conditions exist on a spectrum. And if someone's on the the far extreme of the spectrum, so quite unstable, who's at risk of self-harm, then of course I would want them to be more closely monitored and I would opt for a residential withdrawal management. However, I find, especially with a lot of patients with borderline personality disorder, the more you explain the process to them, decrease the uncertainty about the withdrawal management process itself. A lot of the time for patients with borderline personality disorder, the thing that is most stressful is the uncertainty of a condition or a management plan. Explaining things in detail, answering questions, showing where help is available. I don't think just the diagnosis of borderline personality disorder should exclude someone from a home-based withdrawal.
That's an important point to make. The diagnosis per se is not an automatic exclusion. And as you say, it's all about understanding the continuum of severity. What about things like the physical comorbidities, cardiorespiratory disease and hepatorenal disease? Where do you stand on those issues and home-based detox?
I must admit, it does depend on the condition. For a condition such as, say, severe sleep apnea, for someone with significant liver impairment or renal impairment, I must admit I would probably prefer a residential withdrawal for a patient like that. And that is, again, for patient safety. We are using medications that are sedative, that can accumulate in the body if the liver function is not optimal. So for patients who have pretty significant cardiac, respiratory, liver, renal conditions, my main focus is patient safety in this. If I can go along with the patient and their desire for a home-based withdrawal, I will do my best, but the main issue is safety. And if I feel safety cannot be guaranteed, I will pass on my apologies to the patient, but say my recommendation is a residential withdrawal.
Yeah, and I think it's important to have those clear safety boundaries because it's very easy to be swayed one way or t'other and make the wrong choice when you lose sight of, the first ethical principle in medicine, which is primum non nocere. First, do no harm.
Absolutely.
Safety is paramount. Yeah.
And sometimes I find doctors can get, I don't want to use the word sucked in, but we sometimes see patients who are quite desperate and they come to us and say, "Doctor, please, I'm going to stop drinking soon. I need you to help me do a home-based detox now." And in a situation like that...
What about, "Doctor, I've already stopped drinking. Please start me on the Valium and it's Friday at 4:00. That's actually a very good point. What would you do in that situation? Someone comes into your surgery or to your clinic. You're kind of vaguely aware of them, but you don't know them that well. And they say to you, "I've stopped drinking. You need to help me now and give me Valium for the weekend to get over my alcohol." What do you do? What would you recommend?
I think this is a highly dangerous area that we're treading into. Home-based withdrawals, by definition, are planned procedures. So we've risk-stratified the patient, we've organised what we're going to do, we've organised when they're going to come in to see us, and we've set an end date for treatment. When things like this pop up, and sometimes you do see it, I've seen a couple of patients be given large quantities of diazepam with no supervision for home-based withdrawal, and I blanch when I see things like that. In a situation like this, when we feel that we're being pushed, I think safety is the main thing. I would tell the patient, "Look, I'm going to have to risk stratify you for a home-based withdrawal. This is not a rushed procedure, and sometimes you may have to say to the patient, I can't help you today in the way that you would like me to help you. I can provide some supports for you. I can organise some AOD counselling. But with regards to a home-based withdrawal, once I've risk stratified you and figured out what we can do, then maybe we can support it. But today might not be that day." And explain in detail your reasons and rationale, because I find the road to hell, as we know, is paved with good intentions. And with patients who are coming to us where we don't know their history, who've said they've stopped drinking, there's no guarantee that they are going to stop drinking once we've given them, say, a large quantity of Valium or something else along those lines. Would you agree with that, Fergal?
Totally, totally. And you know, it's very difficult to say to someone face to face, no, you're not going to give you benzodiazepines today. And then they will also say to you, well, what do you expect me to do, doctor? And as hard as it may sound, you actually have to tell them, well, look, you cannot do your own withdrawal. Therefore, I would recommend that you continue drinking, but not at the amounts or in the quantities that you would normally do. I would recommend that you gradually reduce your alcohol use over time if that's something that you want to do, and we will certainly review you again, say Monday morning. But in the meantime, you need to continue drinking something. You cannot stop suddenly. Now, those words, those words of mine have been misinterpreted frequently to me, and it's been fed back to me from various sources that I encourage alcoholics to drink alcohol, and I don't help them. It can be very difficult to say what needs to be said, but safety, primum non nocere, needs to be borne in mind.
Absolutely. Now, going on to some of the practicalities of, say, a home-based withdrawal, what medications would you use, Fergal, and is there a protocol or paradigm that you use at all to manage patients for home-based withdrawal?
Well, I think that's a huge discussion in and of itself. What medication do you use for any alcohol withdrawal? So, I mean, the fact that there are so many therapeutic options just speaks to the fact that we still don't truly understand the full extent of the management of alcohol withdrawal. But notwithstanding that, the tried and tested therapeutic intervention is benzos. Benzodiazepines are proven to reduce symptom severity and reduce the progression to seizures and alcohol withdrawals, hallucinosis, and also delirium tremens. So it reduces the incidence of complications of alcohol withdrawal. And even after you've had a seizure, benzodiazepines will also reduce the risks of subsequent seizures. So they treat all aspects of alcohol withdrawal. So the trick is to get the right benzodiazepine at the right dose at the right time. How one does that is an issue. So there are various regimes. So you can, first of all, the choice of benzodiazepine. What would you say to the choice of benzodiazepine, Philippe?
It does depend, again, on the patient. For most patients, it will be diazepam. However, for patients who've got significant liver impairment, so in the liver, diazepam is broken up into oxazapam and temazepam. When you've got significant liver failure, usually Child-Pugh C liver cirrhosis, that can be impaired, and with large quantities of diazepam, that can build up in the body and cause sedation. So for patients with significant liver impairment, usually we would use oxazapam. So short answer, either diazepam or oxazapam are the conventionally used medications, benzodiazepine medications for withdrawal management.
So you've mentioned oxazapam as an alternative to diazepam. When would you consider oxazapam and why?
I would consider oxazapam in patients who have significant liver conditions or complications, mainly Child-Pugh C cirrhosis. Usually in the liver, diazepam undergoes phase 1 metabolism breakdown into oxazapam and temazepam. For patients with significant liver impairment, that does not occur, and you can get a build-up of diazepam, which can cause significant sedatory effects to a patient. So the long and short of it is we would use diazepam for the vast majority of patients, and for patients with significant liver problems, we would use oxazapam to guard against oversedation.
So what I'm hearing then is that oxazapam does not undergo phase 1 metabolism because it is in of itself a product of phase 1 metabolism from diazepam. So there's
Correct.
no phase 1 metabolism, therefore it is less likely to accumulate in situations where phase 1 metabolism is knocked off, and therefore it's safer. Is that right, Philippe?
Correct. That's exactly right.
All right. So we've agreed then that our go-to therapeutic intervention is a benzodiazepam. How do you decide how much and when to give? What are the regimes that are available to us?
There's a lot of different regimens, and we've talked mainly about home-based withdrawal management, so we'll talk about dosing for home-based withdrawal management, because residential would be a different combination. There's different guidelines. There's the Turning Point guidelines. There's different universities and hospitals have their own guidelines. But I think a good rule of thumb would probably be, it depends on the day. It would be daily pickup of the diazepam. But on day one, something along the lines of 5 to 15 milligrams QID or 4 times a day. Day 2, 5 to 10 milligrams 4 times a day. Day 3, maybe 10 milligrams twice a day. And day 4, something along the lines of 5 milligrams twice a day. And after that, potentially stop. That's just a rough rule of thumb. Does that sound reasonable, Fergal?
Yeah, that does sound reasonable. So, as you say, there are specific variations, but, basically you're talking about fixed dose scheduling. So you predetermine the dose. Yes, there may be a range, but you predetermine that dose range and it's tapering downwards. So it's quite high in the first couple of days and moderately high in the middle 2 or 3 days and then low and taper to 0 in the last couple of days. So you're looking at a 4 to 5 day duration of giving benzodiazepines, which kind of equates to the Monday you start. So I like to start home-based alcohol detoxes on a Monday, and I like to finish them on a Friday, which is why you can't really start at 4 o'clock on a Friday afternoon. So everything's, for me, I think of a 3-week schedule. Week 1 is all the planning. Week 2 starts on the Monday and ends on the Friday, and that's actually the detox. And then week 3, you start initiating the relapse prevention. So, that's how I conceptualize the whole process. It's not a rushed job by any means. But then that reminds me, what tests and investigations would you do, or what clinical assessment would you do for a patient before even initiating an alcohol detox?
I start off with the standard screening blood test that we normally do for patients. So I do a full blood examination, kidney function. Liver function's of particular importance because you would like to know where the liver impairments are and how their liver function's going. You could do a coagulation profile just to check the synthetic function of the liver as well. Yeah. You could do iron studies, nutrient levels as well, B12, folate. If you were so motivated, you could do a thiamine as well. Liver ultrasound is probably not unreasonable. And again, I think that's a good set of broad baseline screening tests. You could probably throw in a few other nutrient tests or values along the lines of, you could do a calcium, magnesium, phosphate, but just a standard screening test. And we've got to be mindful that a lot of our patients who drink heavily can be quite malnourished, and we do need to guard against that as well. So it's good to do a good nutritional history, and if they might need extra thiamine, make sure that that's also prescribed for them while they're undergoing withdrawal management. Does that sound fair, Fergal?
Yeah, there's a number of points that I just want to focus on what you've just said. I mean, I agree with it totally, but I mean, the liver function, that's a great topic in and of itself, but I'm particularly looking for, first of all, the signs of alcohol exposure. So we're looking for GGT and also MCV rises. They'll tell you if you've got significant alcohol exposure. So as you know, we'll discuss this in another episode, you can't really use naltrexone if you've got significant transaminase rises. And then, as you've also mentioned, the INR, to me, if someone's got a deranged INR, they really don't have much synthetic reserve. That, to me, would be a contraindication to a home-based detox. I do not want that level of hepatic impairment being withdrawn at home. The other thing is the risk of malnutrition. So we know that people who are already pre-malnourished are also at risk of, or higher risk of, Wernicke's encephalopathy. So you really want to make sure you've got good baseline malnutrition. And you mentioned blood tests for the risk of Wernicke's. So I've never actually done this, but theoretically you can do red cell transketolase levels or plasma pyruvate levels, and the elevations suggest the risk of Wernicke's. I've never done it. But again, it's all about assessment, and assessment also includes history. So if someone's drinking more than 15 units a day for years, they're at high risk of alcoholic malnutrition. They're at risk of Wernicke's. If someone's already got pre-existing malabsorption for whatever reason, they're at risk. If someone's already thin, you're looking for someone who's thin and hasn't looked after themselves from a nutrition point of view. They're at risk of Wernicke's, and you need to keep a sharp lookout for Wernicke's, as we've already discussed in previous videos. And then in terms of the therapy, we've discussed we're going to be using a home-based fixed-dose schedule of benzodiazepine. But it's not just benzodiazepines. We also need to include the consideration of thiamine in our management regime. So how do you go about approaching thiamine dosing?
Thiamine is pretty poorly orally absorbed. There's an argument that for every 30 milligrams of thiamine you take up, only about 4 to 5 milligrams are actually absorbed. I'm usually pretty aggressive with thiamine, to be honest with you. I usually prescribe 100 milligrams 3 times a day orally if I'm going to be doing it in a withdrawal, just so it's better absorbed. It's a very important thing not to miss. And Wernicke's, I feel, like you, Thurgood, is underdiagnosed. And I think at post-mortem, we diagnose far more people with Wernicke's than we ever do while people are still living, unfortunately. And on that cheerful note, I think we've crammed a lot into this episode. Thank you again, viewers, for your patience with us. And thank you for listening to the Cracking Addiction Show. And we'll see you in the next episode. Bye for now.